Amenorrhea is the absence of having a menstrual period. Primary amenorrhea is the absence of menstruation by age 16. All females should have their first menstrual period by age 16. If at age 16 they have not had their first menstrual period, they should be referred to a physician or a healthcare provider in order to do some evaluations to see why they haven't had their first period. Secondary amenorrhea is when a patient has had their period but no longer has their period for some reason. The most common cause of secondary amenorrhea is pregnancy. Some other causes of secondary amenorrhea include breastfeeding, exercise, low body fat to lean muscle ratio, the use of hormonal contraceptives, and stress. With amenorrhea, the nurse should be involved in the treatment, which includes identification of the cause by the healthcare provider. The nurse should then develop, in collaboration with that healthcare provider, a treatment plan, and then go back and evaluate the plan. Obviously, if the issue is amenorrhea, in order to evaluate the plan, the woman should have their menstrual period. Dysmenorrhea is pain during or shortly before menstruation. It's also known as cramping. Primary dysmenorrhea is associated with an abnormally increased uterine activity. It's typically due to myometrial contractions induced by prostaglandins, and there's no underlying pathological cause. Secondary dysmenorrhea is associated with some sort of pathological cause. These possible causes would include pelvic pathology, adenomyosis, endometriosis, pelvic inflammatory disease, endometrial polyps, or myomas. Treatment of dysmenorrhea, we try to use non-invasive or medicinal causes or treatment plans first. This would include heat to the lower abdomen, a lower back massage, euphilage, biofeedback, a TENS unit, meditation, yoga, good exercise, good nutrition. Those are usually done first prior to using medications. Some medications we can use for dysmenorrhea include oral contraceptive pills, which then thin the endometrial lining, NSAIDs to block the prostaglandins, and also some herbal supplements. PMS and PMDD. PMS is physical or psychological symptoms beginning in the luteal phase of the menstrual cycle, meaning the second portion of the menstrual cycle. PMDD is a more severe form of PMS. Causes for PMS and PMDD are unknown, but symptoms include fluid retention, behavioral emotional changes, premenstrual cravings, headache, fatigue, and backache. The medical management for PMS and PMDD includes not to smoke, to decrease the intake of refined sugar, salt, red meat, alcohol, and caffeinated beverages, follow a good nutrition plan, exercise, and potential counseling. Medications that can be prescribed by the healthcare provider include diuretics to decrease the fluid and edema, NSAIDs, oral contraceptive pills, and SSRIs like Prozac, which in use for PMS and PMDD, Prozac's name is Sarafem. Nursing diagnoses for PMS and PMDD include fatigue, excess fluid volume, deficient knowledge, and acute pain. Endometriosis. Endometriosis is characterized by the presence and growth of endometrial tissue outside of the uterus. Theories of how endometriosis develops includes a transtubal migration or retrograde menstruation. Both of that means is that the endometrial tissue, instead of coming out through the vagina with the menstrual period, the actual endometrial type tissue flows back through the fallopian tubes. And since the fallopian tubes are not actually adhered to the ovary, then the endometrial type tissue starts to float in the abdomen. Symptoms include pelvic pain, dysmenorrhea, dyspareunia, which is painful sex, abnormal menstrual bleeding, and infertility. If you look in figure 6.2 in your book, you can see common sites for endometriosis. They include the ovaries, the fallopian tubes, the outside of the uterus, the cervix, in the vaginal vault, and also other places in the pelvic and abdominal cavity. Management for endometriosis is NSAIDs to reduce the pain, Oral contraceptive pills to decrease the endometrial lining, which then helps limit the damage of the endometriosis. Hormonal antagonists, and possibly even surgery. There are some support groups for endometriosis and victims of endometriosis, including Resolve and the Endometriosis Association. Again, this is a very similar figure to the one in your book. This is figure 6.1. In your book, it's known as figure 6.2. Oligomenorrhea is decreased menstruation. There are lots of possible causes for oligomenorrhea. Menorrhagia is intramenstrual bleeding from spotting to hemorrhage. Causes for menorrhagia include an ovarian cyst, a myoma, which is a fibroid tumor, miscarriage, multiple sexually transmitted infections, or endometriosis. Menorrhagia is excessive menstrual bleeding. Anytime you have a patient ask you or state they have an alteration in their menstrual cycle, especially with bleeding, you need to have them describe that. What my viewpoint of a heavy or a menorrhagia or a heavy menstrual period is and what an 18-year-old's viewpoint is can be totally different. An 18-year-old may complain of menorrhagia, and that would be just wearing a tampon during their period. My view of menorrhagia is they bleed through a super tampon and a pad within 1 hour. So it's important to ask questions to get detailed information from your patients. Dysfunctional uterine bleeding is excessive uterine bleeding with no demonstrable organic cause. It's most frequently caused by anovulation or any condition associated with continuous estrogen production. Causes include pregnancy-related conditions, some lower reproductive tract infections, benign anatomic abnormalities, neoplasms, malignant lesions, trauma, some systemic conditions, and there's also iatrogenic causes. Management for dysfunctional uterine bleeding include oral contraceptive pills, the use of Premarin and progesterone. They may also use laser ablation or surgery.